she is now a well-established researcher. The University of Reading is known for its interest in clinical linguistics and the application of linguistics in aphasiology. And that is where she is now. I'm hoping that her presentation today and her interaction with all of you will lead to a very healthy collaboration. It is time that we establish India as a major contributor in these areas. When I see what has happened in Korea, when I see what's happened in countries like Malaysia, Singapore, which stepped into our field much, much later than us, it is sad that we don't have a presence in cross-linguistic studies in the acquired language disorders. Dr. Arpita Bose is one of the recognized names, and I look forward to listening to her, and even more so to her initiating collaborations in India, supporting the younger researchers here, and setting up a robust collaboration with Indian scientists. So we look forward to hearing you, Arpita. It's a pleasure and an honor to have you with us. Welcome.
Thank you, ma'am. Thank you all for organizing, particularly Sonal and Sunil for inviting me. And when I saw on that card that the chair is Dr. Prathibha Karanth, I was very excited. But at the same time, I was very nervous because she was my teacher and she was very inspiring. If you hadn't had her as your teacher, you will not know. And partial reason for my interest in aphasia was, that time she was still a faculty in Mysore. And, I aspired for her dignity, for her composure to think. So I'm very excited to present this work to all of you. And also, as I said, I'm a bit nervous because Karanth ma'am is here. But as I said, as Karanth ma'am was saying that, India provides us opportunity to address so many interesting theoretical and clinical questions, which is not feasible in many other countries. And that what captured my interest. And I'm now in aphasia field for more than 24 years. I always wanted to work in Indian languages, but that did not happen until last 6 or 7 years. So this was the work I have done with several colleagues. And I hope, if this is of interest or if you feel inspired by it, or please do get in touch and we can find ways, to explore interesting questions. So without due delay, I start. I have one question is, how much time do I have?
Ma'am, we can have a 45 minutes talk and we can have 15 minutes of discussion.
Okay, that's fine. So will somebody tell me when I have done 30 minutes so that I don't want to, keep.
Sure, ma'am.
I would like to have discussion more than anything. So let me just find my mouse. Yeah. So thank you all. So as I was saying, this work was motivated by the fact that, Indian languages provide a lot of interesting questions which we can actually explore. So how I have this work, let me go see if I can move. Sorry, this is not going through. Sorry, I'm trying to move my slides. Okay, it will move now. Yeah. So this type of work, I will present work in 2 disorders, is not possible to do alone. A lot of students have collaborated. A lot of my colleagues in India, linguists, neuropsychologists, some of you know these people. I can see Ronita in the crowd. Manaswita was one of the collaborators and she graduated from Manipal, I believe. So it's a joint work. I'm just presenting, this collaborative work to all of you. Now, sorry, just trying to find my way. So how I have kind of structured this talk is, first I will tell you what really motivated me to undertake this research in terms of the populations as well as for choice of task and methodologies. Then I will present data from Alzheimer's disease. Second, I will present data from post-stroke aphasia and then I will try to integrate the findings from these two disorders. And I would really be interested to discuss your question. What do you see as research opportunities, or what do you see as challenges? I do have a couple of slides, but it might be more interesting that we discuss this than me talking to you all. It's a long talk. I have tried to keep it short that I can hold your attention, but across different sections, I can pause and take some preliminary questions and then go on to the next section. So why it is important to understand linguistic breakdown in different languages? So this is 1990, and since then many authors have said that, or have shown that, most aphasia research is from English and other Western European languages. And this is a review paper by Beveridge and Back in 2011. It's already 10 years old. If you see here, it lists the population, world population. So China has highest population. And then, it lists the, the number of speakers, population percentage. And in aphasia research, it is from a review of 4 journals, how many papers are published in that language. So if you see, 5% of world population speaks English, but 62% of aphasia research is from English-speaking individuals, right? And that's quite problematic. So if that happens, and all other languages are underrepresented, Spanish, Arabic, Hindi, Bengali, these are huge global population who speaks these languages. So, and with the aging changes, with, you will have higher incidences of stroke, dementia. So you will see language breakdown. But what has happened because of this English focused literature is we believe, or we have come to believe, that the language breakdown you see in English participants, you will have the similar breakdown in other languages, which is very not true. And that makes the situation difficult to really separate what are the universal mechanisms of language specific content and what are universal from language specific contents. And other inflectional statement, which has, which I kept thinking when I was a master student in Mysore, I used to read a lot of articles in the library, and I was interested in bilingual aphasia then in 1996, 97. A lot of the articles were by Michel Paradis. He's in Montreal. And he, in 1988, one of the articles, he said, language impairment depends on how the system can break down, which is dependent by the structure of the language. And this remained in my mind for a long time. And I kept thinking about it, that if it depends on the language, how the language deficits would look, then why people are not doing some things about that. So, there is a recognition in the literature that we need to understand language breakdown, in this case, whether it's children or adults, across different languages. And then only we can actually have a clear understanding is what are the core deficits across different disorders, whether again for children or adults. So these are the kind of motivations which really prompted me to undertake this work. Now, if you have listened to my talk, I apologize. I use this picture of language tree often. It just shows in Indo-European languages, the distribution of language. And this is a nice visual illustration to indicate, how languages are different. So as I was saying, there is plenty of literature in English, Italian, Spanish, German, Greek, Dutch, French. But as you can see, as I'm populating the right-hand side of this tree, there are some literature now, but the left side of the tree is quite impoverished. And, English is just one language in this whole tree in the world of different languages. Okay, so with that consideration, we have limited characterization of the nature of impairments, both in monolingual and bilingual speakers in neurological impairments in non-European languages. And initially I got interested in this because often, if you have seen what are the diagnostic criteria of dementia, especially PNFA, like non-fluent primary progressive aphasia, one criteria is actually agrammatism, right? And agrammatic characteristics are very well laid out in English. But then what will be the agrammatic features in Bengali? So if they are different, so if a client comes to your door, then you got to know what are the features you are looking for. And it's really difficult to then, use those English characteristics for other languages. There will always be an overlap of characteristic because we are talking about languages, but still there will be language specific characteristics. So in this research, I address some of these issues by studying Bengali. And so to explore the linguistic manifestations. And as Dr. Karanth was saying, that obviously all this has clinical implication. I'm also very driven in the theoretical understanding of these disorders. I think, if you're practicing clinically, you don't have much time to think about the theoretical underpinnings of what breaks down or what doesn't break down. But I think in long-term progress in the field will come if we have strong theoretical, motivation for our work. So I am interested to answer both theoretical and clinically relevant questions. And I have in my work, this is very simple task. And so I have been in aphasia for some time now, and I have used neuroimaging, very fancy techniques. But over time, I realized the type of research questions that you can ask with simple tasks and with patient population, you can ask very interesting questions. So what I want to emphasize many of you practicing clinically, that even if you are doing simple behavioral tasks, if those tasks are robust and if they are done well, you stand to inform quite a lot to the literature and to the field. So don't undermine yourself if you are not having very fancy techniques, okay? Now, I don't think I need to explain to this crowd the two populations I'll report today. One is post-stroke aphasia and one is dementia, Alzheimer's disease. So I'm talking about post-stroke. So it's a sudden stroke and then you have aphasia. So it's not like PPA, it's not primary progressive aphasia. So there is a neurological event and then you have a language deficit. And the other one is Alzheimer's disease. So it's not, again, no other kind of dementia. It is the AD patients we report. And the task we have used for this study is connected speech. So I have used connected speech task to really characterize, what are the production characteristics of individuals who have AD and those who have post-stroke aphasia. Now, as I was mentioning, that there is very well-established narrative production characteristic in monolingual English for agrammatic aphasia. So, at a structural or syntactic level, you have, non-fluency, short phrases, oversimplified sentences, limited number of complex sentences. There is a host of lexical features like, they have problem with closed class words. The production is weighted more towards noun. They have difficulty with noun and verb morphology or any morphological features. Even in AD, there is clear syntactic structural difficulties, as I laid it down here. These are from English literature. But the language deficit in AD is less severe than in agrammatic aphasia, but they do show differences in the language production. In contrast to agrammatic aphasia, people with Alzheimer's disease often produce very high proportion of pronouns, which is in substitution of the nouns. They have reduced noun, but higher pronoun. Sometimes proportion of verb increases, but not always. And they may or may not have difficulty with inflection and morphology. One key thing in AD or any dementia literature is difficulty with the semantic content, reduced semantic content, idea density. So this is just to lay you a brief overview of what are the different types of deficits you see in these two disorders. So the driving question for this research is then what happens in structurally different languages? For example, in this case, Bengali, are there language specific diagnostic markers? Are there language specific deficits we see. Now, it's very reassuring. I have given this talk to, not this talk, but similar talk to other places where I go on to explain what is Bangla or Bengali. So here are some demographic, ethnographic details. But I just thought to recapitulate some of the key features which are relevant for our study. First is, the syntactic features in Bengali is different from English. So it has a different word order, SOV as opposed to SVO. Bengali has very flexible word order, and it often happens in the languages which have higher level of inflection and morphosyntax. If the morphosyntax is complex, it's often have a more flexible word order. Bengali language have rare use of passives only in written form, hardly ever in spoken form. And Bengali is a pro-drop language. So this might be a new terminology. Pro-drop language means that once a person says, refer to a noun, in the subsequent mention of the subject, it could be dropped. And you can infer the noun from the context as well as from the inflectional properties of other word class. So here, if somebody says, Amar ma boigyanik, which is my mother is a scientist, university te kaj kore, works at the university. So the listener or the person actually knows this person is talking about the mother. So English is not a pro-drop language. So you have to have a mandatory subject. And this has key implications for the diagnostic marker of more pronouns. In English, overt excessive production of pronoun is a key feature in diagnostic for dementia. So what happens in pro-drop languages? Do people produce more pronouns as they do it in English? So that's another question. Like any language, Bengali has noun, verb, adjective, all those sorts of things. But Bengali has postposition. Postpositions are like prepositions, but because it's after the noun, that's why postposition. And Bengali has fewer word class. Again, the things like auxiliary, modals, what are served in English as different word class are served within the inflectional properties of the major word classes like noun or verbs. And many Indian languages has something called reduplication. You duplicate a sound. Sometimes you have phonological changes, sometimes you not, for emphasis. And again, that is something, it's a word formation process, right? So in English, we don't have that. Keep that in mind. And then going to the inflectional property, it's not a linguistic class, and I don't want to bore you with that. Just the take-home message is noun and verb inflection is quite extensive in Bengali, and verb is more complex inflection than noun. And it is rich, extensive, and agglutinative. So it adds, the component adds after each other in a particular way. So for example, here, the final form is korchilam. It can, in the next one, korechilam. So you can see number of markers added. And again, there are differences with Bengali with other Indian languages. Irrespective of that, the main thing you can take from it that, many of the Indian languages are agglutinative. So you have to keep adding, and you cannot just drop, say, IL or E and then make a new word. And we can talk about this later. We just published this paper last week about, if you are interested to read more about these two languages differences in this paper, it's freely available. It's a Frontiers paper, and I can send you a copy if you're interested. Sorry. Okay, so with this background, so I talked about the agrammatic features in aphasia, language features in dementia, little bit about the characteristics of Bengali. And the main goal is to document and characterize language production characteristics for Bengali English bilinguals. And I report here mostly Bengali, and I can talk to you if you are interested in the cross-linguistic aspect. And what we are concerned here is about the micro-linguistic characteristics of Bengali. And I also was interested in cross-linguistic patterns across similarities and differences across domains. And also between pathologies, what are similarities and differences. So with that, let's get on. So I will go on to present the data on Bengali speaker first with Alzheimer's disease. This paper is just published with my colleagues here. And again, if you're interested, you can search, or I can send you a copy through you can email me over through the slides. I have given my email address. Now, why we did work in connected speech. If you see my publication, most of my work is in language production, but single word production. And connected speech, and with single word production, it's very interesting. You can manipulate various type of things. A lot of things come out of that. But again, single word is not realistic of communication, right? So when you are communicating, you don't speak in one word. And so connected speech has much more ecological validity, and it generates richer amount of data. And depending on your interest, you can explore, say, phonology, syntax, semantics. You can explore macrolinguistics aspect, turn taking, you name it. You can do way more things with connected speech. And for practicing clinician, connected speech is a quick task to administer. And if we can figure out, some features within the connected speech, then it's a quick way to aid diagnosis, or at least aid in the process of the diagnosis. Somehow the world has the same idea. So I just for fun, there are 4 connected speech review on AD or neurodegenerative diseases in the last 3 years. So it must be quite useful. In context of AD, connected speech shows decline in pre-symptomatic stage. So really what you are trying to get is to get to these patients quickly before they get symptomatic, because by the time they're symptomatic, they're already into the disease quite deep. It has been shown to be useful in monitoring disease progression, and in some cases, it is a supplementary markers in young onset AD. And from these connected speech literature, what they recommended is we have to know features across different domains, speech production, syntactic complexity, lexical, and you can see fluency, semantic, discourse parameters, and other variables. So this is a part of the systematic review. But again, the key features which distinguish AD speech from control are listed in this bottom figure. And again, if you see use of pronouns, they suggested as one of the key features, okay? So increased production of pronouns. So if that is the case, along with other things, what would happen in a prodrop language like Bengali? And these systematic reviews, 90% of the papers covered were from English. Okay, so there were papers from French, Brazilian, Portuguese, Hebrew, Chinese, Japanese, Italian, German, but none was picked up, which made the criteria of the systematic review from Indian languages, which is a shame. But you guys have a lot of expertise and knowledge. I think we can change the landscape of the literature. So with that in mind, and with the thing that language can get impaired depending on structure of language, we then need to assess our approach of continuing to utilize linguistic diagnostic criteria derived in English for other languages. So what we did is, let's see. So participants were, there were 10 people with Alzheimer's disease. And for this study, only 6 of them could do the task. And all the details are presented here. And one thing I wanted to highlight here is, dementia severity on CDR. They were mild, mostly mild. One of them is moderate. And, you can ask me a question why this is relevant now, why I'm highlighting it. I can talk to you about this. And this data was collected in Calcutta. And now coming to the experimental task, I spend a lot of time with my collaborators to think what could be a good experimental task. For a task, for a really good understanding of how the production is, you need a task which is long enough to show variety of utterances. And that's the key thing. And in English literature, people have used Cinderella narrative quite effectively. But in India, if I used a Cinderella story, ask them to retell me the story, it's quite irrelevant and many people will not know it. And then you are tapping into something else rather than actually their language production. There is, of course, picture naming, but picture naming has its problem because we have the data from picture naming that are not present. Is picture naming encourages listing of the lexical item. It does not allow you to produce a very productive language. You can ask them to produce, okay, can you tell in sentences, but it's again very limiting in terms of what utterances you can get. And one of the key thing is, and I can talk to you about this later in challenges, is if you are investigating a language which has not been investigated in this way, it's important to use a task that capture more variety of utterances. So I again spent a lot of time, and finally we went with frog story, where are you? So these are some example of the plates, but it's a story of a frog and a dog, and their friendship, they loses their frog. So the lexical items were easy and there was no cultural connotations, and frog story has been extensively used in child language, and it has been used by Grossman's group in adult language as well, especially in dementia. So I wanted to have some task from findings from which I can then compare with the literature, so the literature can build. And also if somebody is interested to look at this data again, can do it. So we use the frog story. I don't expect you to read this. This is Bengali transcript of somebody with Alzheimer's disease. This is just half of the transcript. So the key thing for you to take from here is they produce a lot of language, okay? But that doesn't mean that it is a very well-structured language. There is a lot of repetition, lot of various things I'll show you next. And here is just a more, again, it's a very busy slide, I know, but what you want to see is this color-coded things, what I'm saying. Here, there is verb missing, there is repetition and revision. Again, there is repetition and revision. There is unspecificity of subject. There is often overuse of same construction, object missing. So, often the people with Alzheimer's disease, they revise, repeat, have a lot of unspecified information. They get stuck in, the story narrative. They get stuck on one aspect of the story and can't move forward. So, these are characteristic features, and you don't need much help, but you can see the sentences are short. They are not very well embedded, as opposed to, somebody with kind of neurologically healthy. They have compound sentences, embedded sentences. So this is just a characterization of how these two samples usually looked. And here is the same person who said it in Bengali also had it in English. Again, this is only 1/3 of the transcript or half of the transcript. So in contrast, those of you who are working in aphasia will know, this is a lot of language production, right? And because it is in English, I leave it on the screen for a bit so you can read a little bit and you can see the repetitiveness of thought, repetitiveness of the syntax structures, or the lexical items. And interestingly, this person keeps on actually reflecting where the problem is. He's saying matha boro gondogol korche, which basically means my head is playing up. Memory kaj korche na, memory not working. Memory te asche na, memory, he can't get in the memory. So, you see these reflections of his actual problem. Okay, how I am doing on time?
Hello.
Yeah, Sunil, how much?
Ma'am, you still have another. You're about to complete half an hour, no? You
Okay.
have just completed 40 minutes approximately.
Okay, that's fine. So, with these samples in mind, what we went on to analyze is, because again, connected speech is a very multidimensional, production. You can do various things, and we chose what's called QPA, quantitative production analysis, because that has been shown in the literature to be most used, and I again wanted to keep it consistent with the literature, but we augmented QPA with semantic analysis as well as specific linguistic features needed for Bengali. So, there we added features what we think we needed. And again, if you have single case studies, they are useful things to report in the literature because, statistically, there are a lot of strong methodologies from neuropsych, which can be very useful to, report in a robust way, even simple case studies. When you do this type of analysis, if any one of you have done, you will see you can come out with loads of variables, and you don't need everything. You just need to focus on what's important. So, or what is in the literature says it's important. So what we did is, again, rate, struct, syntax, lexical feature, morphology. You have this set of tables. And what we found is, obviously, people with dementia, AD, had slower rate of speech. They have problem with their structure and syntax, smaller MLU, proportion of well-formed sentences are reduced, and poor embedding. Okay, and they showed up in terms of statistical differences. What's also interesting, what I wanted to show you, because individual variability is the key in neurological disorders, is how many of these 6 ADs were showing this same pattern. Okay, so you can see in embedding index, mean length of utterance is problematic for everybody. What's interesting is they did not have, actually, they were mild AD. They have problem with pronouns, but it was not overproduction. It is decreased production of pronoun. So that's a very contrastive finding to English. Okay, English, we produce more pronoun, and here we produce less pronoun. And I can talk to you about that, why I think so. And they had fewer reduplications. And noun inflection, there were no problem with the noun inflection and no problem with the verb inflection. So whatever tokens they were producing, they're producing it correctly. And that's very important to realize, because in English, there were often marked difficulty with noun and verb inflection. Having said that, they were producing, at least in noun, different types of inflections and limited variety. There were problems with the semantics, both CIUs, idea density and idea efficiency, and there were more disruption of fluency. So why this type of inflection is important? So they produced no problem with inflection. So whenever they're producing a noun, if it needed to be inflected, they produced it correctly. But AD individuals were producing more of what is this called definitiveness markers. These markers are much easier than other types of markers, than case markers. Okay, so again, if you have then subsequently develop a tool of different case versus marking just in, to elicit in AD, you should see a difference in those type of parameters. So the key findings from this is people with Bengali AD actually showed similar patterns to English, in terms of reduced utterance length, simplistic construction, but they had fewer problem with well-formed sentences. Only 2 AD people had difficulty with their sentence well-formedness. And I think it's because we have more flexibility in word order. This is a contrast with English, decreased production of pronouns. There was no problem with the verb and noun inflection, but limited variety. Okay, limited variety, and there were issues with semantic content. So what we see from this is, people with AD does have difficulty, language-specific difficulties, which we can pick up in this type of testing, and their core deficits remain, which is semantic difficulty along with differences in grammaticality, characteristics of choice, and they often opt in for simpler and operationally less demanding options. So that was quite a bit. Shall I continue or shall I pause?
You can continue, ma'am.
Okay. So moving from here to speakers with aphasia, again, all this literature is marked by limited N, and this work was done by Abhijit. Here we report, I have just 3 data points from people who are non-fluent aphasia, and I report the Bengali characteristic. If you want to know more about these patients, it is published in this article. And here I just give you again a transcript of this Bengali production. You don't have to read it, but what I tried to do is just tell the lexical class, okay? Noun, 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 postposition, noun, noun, postposition, noun, verb. So what you see is the syntactic characteristics, it just qualitatively, short and fragmentary, simple sentences, less complex sentences, and even you have strings without verbs, right? So that's characteristics of agrammatism is noun is more, less verb. In terms of lexical characteristic, again, it's more noun, less verbs, and they were using reduplicated expression. And across these 3 patients, there was not a single pronoun. There were limited adjectives or adverbs, okay? And wherever they were producing inflections, they were producing correctly, but there were some issues with noun inflection, and most of the time nouns were produced. If they were missing an inflection, they were producing it in the bare form, which was correct. This is just to remind you to remember the extensive production that somebody with AD produces versus somebody with aphasia, right? So aphasia, you often have very limited production. And again, we did the same analysis. We did not do the semantic analysis in this. We focused on syntax and lexical and morphological features. And what we see here, because it's just a case series, just 3 people, we have proportion of well-formed sentences. And what we see, 2 out of 3 of them actually have significantly different, less well-formed sentences. And these are significances determined by Crawford, single subject methodology in neuropsych. All of them have difficulty with embedding. All of them had difficulty with utterance length. So they were smaller MLU. In terms of nouns and verbs, there is increased nouns and decreased verbs. BWA2 was kind of spared. And there is decreased close class words. And there was not a single pronoun across the 3 transcripts. So this is often you see verb to noun ratio, noun to verb ratio. And again, this mirrors what we often see in agrammatic literature in English, right? Increase in nouns, decrease in verbs, and problem with verbs. In terms of noun inflection and verb inflection index, they had no problem with when they're producing verbs, but they had problem sometimes in noun inflection, they were producing in bare nouns. And whenever they produced the verb, they had limited variety, but whatever verbs they produced, they produced it correctly. And we can again discuss this further, and this is very interesting. And as Karanth ma'am was saying that, she moved to AD and she learned a lot from that. I could not believe, I had real discussion with my colleagues who work in child language. I could not believe I'll say that. And I learned a lot about language breakdown and language acquisition, how children, multilingual children acquire language. And some of the explanations I came up with is from the child language literature, is thinking about how the languages can break down in either extremes of the age group or populations. Sorry. So here are the key findings. In interest of time, I just showed you, this is a tabular form. But what I want you to focus is there will be variability across people with aphasia. You see it here, that BWA did not have all the features what you see in agrammatic aphasia, but she did have few others. And what we find with English literature, there are similarities as well as differences. And one thing I want you to go away is Indian languages are more complex in morphosyntax. And that does not mean it is more difficult for people neurological impairment. A lot of time there would be misconception that if a language is more complex, it is more difficult. That's not the case. It is because, because it's more complex, it's more regular and systematic, and that is preserved in your brain. So what happens in English, because, you know, play, played, eat, ate, these inconsistencies make language processing difficult. That's why when there is a breakdown, you see breakdown in those. But in Bengali, it's very regular, systematic, but complex. So complexity itself is not a problem. And so with that, in interest of time, I do want to discuss things with you guys. I'll move on to the integration of findings. It's a very loaded slide, I know. So what I tried to do is, what are the similarities? So when an arrow is pointing down, it means they're reduced from the control. And if there are multiple arrows, that means the difference is much more pronounced. So what you see in people with aphasia, there is more difficulty in well-formedness of sentences. Interestingly, people Alzheimer's disease actually had lesser embeddings. And I think it's because they produce a lot of, you know, simple sentences, short sentences, but a lot of them. In terms of pronouns, again, you see it's increased noun, here it's decreased noun. Noun to verb ratio is increased in post-stroke aphasia, it's decreased or similar. And pronoun is reduced in Alzheimer's disease, which is contrast to English. So these are the differences, you know, where there is a difference in the severity. This is contrast with English, and these are much more features which are in opposite directions in the two disorders. In terms of inflectional characteristics, again, there are contrasts to English. The literature says, you know, there is contrast to, you know, there is more problem with verb morphology. We did not see that. But noun inflection is, to some extent, not as good in people with aphasia as they are in Alzheimer's disease. So the main thing, again, you want to take away is that impairments in both these disorders are in line with expected disorders. So which is good news, right? Only because you speak Bengali or Hindi, you don't become something else. So if you have aphasia, so you can trust that, okay, even though I don't have literature in Hindi, Bengali, or in Malayalam, that's okay. You can still have some core features which you will expect to see in a disorder. But then you have to be open-minded to think, okay, this language has these specific features, how that might be represented. And if those features are important for your rehabilitation, whether assessment or therapy, you need to do something about it. Okay, so people with aphasia have more difficulty with verbs. AD had more difficulties with nouns. Aphasic have more difficulty with syntax and morphosyntax. AD had some difficulty, but not as overwhelmingly as aphasic. And AD had severe semantic deficits. People with aphasia did not have that prominent semantic deficit, but I did not do yet the CIU kind of analysis. This, I think I have kind of said that, you know, it's important to document for a variety of reasons. Cross-linguistic work is fantastic if you can do it. And don't get bogged down by just bilingualism. Okay, bilingualism is interesting, but in India offers you also to study each language on its own, you know, so that's quite fantastic, I think, you know. So that's another point of contribution to the literature. You guys as a researcher or clinician can bring to the literature. And I think some implication is, I'm very interested in theory. I cannot hide my excitement for that, but you know, it improves the theoretical understanding of our language impairments, and I think across lifespan, right? And it provides a framework for cross-linguistic comparison across structurally distinct and underexpressed languages. I think it challenges the notion that more complex morphology may be more difficult. And in long term, I really hope, you know, we can do more work to develop this area and report in the literature for our colleagues and for our clients. And as I said, this work is not feasible without help of my collaborators who have been fantastic. My colleagues, we had so much discussion. I am not a linguist. It was like for me doing another PhD. So I learned a lot from my colleagues, and of course, the participants. Without them, we can't do this, and the money some funding agencies gave us. So I don't want to repeat this, but maybe we can discuss it together, what are the opportunities and challenges. I do have some slides, but I just don't want to keep talking at you. It would be nice to discuss things. Thank you.
Sunil, would you like to open it for discussion?
Thank you so much, ma'am. I now request Dr. Prathibha ma'am to take over the session.
Thank you, Arpita, for that excellent presentation. I will just make a few opening remarks in terms of my own experience with the aphasias, not Alzheimer's. When I was a clinician, aphasia was the focus, and Alzheimer's was, one didn't really worry too much about it. So most of my experience has been with the aphasias. And I would like to, share some of my own experiences and observations, which I think are relevant for both practitioners as well as researchers. I remember as a young clinician, when I began in NIMHANS, my practical experience with aphasics as a student was very, very limited, because we hardly saw 1 or 2 aphasics in a year at ISHA at that time. So one of my first challenges was when I read the literature in English, the demarcation between the fluent and the non-fluent aphasics were described as something that was outstanding. And of course, later when I saw patients who spoke English, I knew why it was such an outstanding characteristic. But when you worked with somebody who spoke an Indian language like Kannada or Hindi, or I'm sure Bengali, that difference is not stark. And that's what comes across in the literature and agrammatism, because we are speakers of agglutinative languages. And your data supports this observation that the syntactic markers are bound and are retained even by our agrammatics. On the other hand, our fluent aphasics do not seem so fluent, again, because the syntactic markers are so tightly bound. So this, difference, clinical difference, which the Western literature made much of between the anterior and the posterior aphasics, between the fluent and the non-fluent aphasics, it is not so stark in our languages. And I think your data also supports that.
So one of the parameter of fluency, right? If you see in BDAE or WAB even, is number of words in a sentence, right? So there are 4 or more words in a sentence, then it goes to fluent, and less is non-fluent. But our sentences are small because we don't have many freestanding words, which are all incorporated. Not all, a large part is incorporated in the inflectional properties of the language. So our sentence length itself is actually shorter than English.
Which is why I've always had a reservation also about using MLU so widely, even with children. Because, if you compare MLU in English as against MLU in Kannada, it's quite different. So I think measures like that are very gross measures, and it's been so extensively used in scientific literature. It's changed now, but for, when I was a student, early part of my career, everybody relied on MLU, and MLU can differ very significantly across languages.
Exactly.
And then again, in terms of, the content, the meaning that you are able to convey is easier. So, I agree with your argument that it can be a strength rather than a weakness. And I have seen this in my patients with aphasia, and it works to the benefit of the patient, that he's still able to, convey this. A second point that I wanted to make was your emphasis on connected speech as against the, words. I think this too has changed over the years, but the point that I would like to make is that when I designed the linguistic profile test, after having explored the phonological differences, the syntactic differences, the semantic differences, there was a section on discourse, which included both the patient's description of his own problems as well as a picture description. And the intention was that you match what you've seen in the first section, covering phonology, syntax, and semantics with the spontaneous speech to see, the differences. And there again, you can extract this kind of an information. A third point that I want to make, I think, which, I would like you to explore further is that not only are our languages inflected so tightly, sometimes, it's even dependent on a signal phoneme. Okay, and I like to give the example of the avano, avalu, avaru in Kannada. Okay, where the person, the noun, and the gender, all three are conveyed with a single phoneme difference. Okay, so when this happens, is this a phonological disorder? Due to a phonological disorder? Is it due to a syntactic disorder? To tease these things out becomes very difficult, but I think scientifically it can be very, very intriguing. Yeah. So I just wanted to share some of my, old experiences with you, because I think these are areas that can be explored. I have used the same method when I worked on the acquired reading disorders, and the book that came out of it basically looked at patients who spoke English and had a certain kind of acquired reading disorder, patients who read Kannada or Hindi, one of our languages, the same subtype of acquired reading disorder, but the difference in the symptoms. And ultimately, what does it inform us in terms of the model of reading in the brain? Okay, of course, with spoken language and receptive language, it's much more complex. But, as you clearly pointed out, I think it can be both a strength and a weakness. And I think it's time we explored the strengths in our languages, which leave us with certain strengths even when we are become stroke patients or Alzheimer's patients. Because that is something that we can capitalize on in therapy also. So, it's been fascinating listening to you, but I thought I'd share some of these, early experiences of mine. Thank you so much.
Thank you.
Would you like to respond that, and then we can take questions?
We can take questions first. So I do agree with most of the things you have said. And I think, again, the Indian languages give us many opportunities to ask both theoretical questions and clinical questions. One thing I wanted to say in terms of connected speech is useful, right? Having said that, it's also important to have more structured tasks. So now I'm telling that, they have problem with syntax or, say syntactic formulation, these patients. We are observing the symptom, but we still don't know why they are having this. So, and then when you have said very structured sentence production task and you manipulate some things, you can get actually what are the underlying reason of that deficit. So in AD, they also have problem with sentence formulation. It could be due to memory, or they could actually be having real grammatical difficulties. So I do think that, this is the first attempt, but a bigger ambitious program should include structured tasks like, naming, sentence production, and then connected speech. And if we have, combination of features from different levels of language processing, I think it could be very useful. And, the whole, I have not done anything with this, is the discourse level markers. It's very interesting when I showed you the people with AD had much more realization why they are having difficulty. You don't say that, you don't see that in aphasia often, that, I'm having difficulty with the grammar, but in the people with AD, they were very clear that there is some issue with my memory. So I think, you can explore the same data in different ways. But
that's where the LPT gives you both.
Yeah.
Initially, it explores the structure, and then it looks at the usage if one does use the discourse part also. But unfortunately, while the test has been extensively used, I think the discourse part has been dropped. Most people, don't do that last section. So let's open it to more questions. Sunil, would you like to read the questions in the chat box, please?
Yes, ma'am.
Also, please feel free to come on the mic and ask. That's also nice. Yeah.
Yes, ma'am. There's a question from Miss Mithali Sharma. Her question is about the verbs in English that adds the suffixes like ed or t are aggluterative, but not many. So what are the categories of verbs in English?
That's a very linguistic question. What are the categories? So, you have whole range of verb, transitive, intransitive, unergative, various various types of verbs. So you have to look up a linguistic textbook for that.
Yeah, linguistics.
Yeah.
Yes. In the disordered speech, did you find any kind of classifiers, or as these are indigenous features of Bengali? Question from Ria Mathur. Yeah.
So what do you mean by classifiers? I'm not sure. So I can comment on, are these indigenous features? So if your question is how, if these features we saw in Bengali we see it in other languages? My prediction would be, if you have that similar language, right? If you have another pro-drop language, you might see similar findings. They have fewer pronouns than more pronouns. So I have seen some findings in Italian where they also have that fewer pronouns. So in Indian language, there are a lot of other pro-drop Indian languages. My prediction would be you might see their difficulty with the pronoun is lesser pronoun rather than more. Again, there are published research in agrammatism in Canada. So if the languages, so that's another thing. If you think of the language in terms of structure, if you have other language with similar structure, then you can predict, it might have similar features. However, that has to be tested.
Hello, can I speak?
Yes.
Hi.
Yes.
Thank you so much for a very nice lecture. Classifiers are they are the characteristic features for a noun. For example, in Bengali, you say ek, to, and ta, and ti. Okay, these are inflectional categories, and they also inflect for gender and for number. So these are the features specifically used to characterize the shape or size or number of a particular noun. So these are the classifiers. I don't know Bengali, but as a linguist, I know these are the particular specific parameters of Bengali language. So do you find evidence like when he is specifying things like ekto, a man, one man, or ekti, those kind of features? Do you find them?
Yeah, so people with AD, they produced way more this type of definitiveness markers. So they were like the or a, cheleta, kukutta, cheleti. Okay, so the case markers were more difficult, and I think case markers were operationally more difficult for people to produce, right? Because boite ache means locative versus determiner, like the boy, the dog. So people with AD were producing way more, if you say it as classifiers in AD. Yeah. Again, I think it is, if you may move away from specific feature, it is that they are simplifying. They are defaulting to things which are easy. But one thing I want to say this to the crowd is, it is very important to have a good linguist on the team who understand linguistics. I am not a linguist. I had the hardest time to really interpret some of it. Okay, so if you think of doing something, you need a very good linguist in your team.
Yeah. No, but you have explained very nicely, even linguistic features. I congratulate you for a very good.
Thank you.
Thank you.
Yeah, go ahead. Sorry, Sunil.
Yes, ma'am. I think we'll move on because it's already late.
Yeah, sorry. Yeah.
Ma'am, there's one question, whether the sentence structures, what we use in South Indian languages, where we have this SOV format, whether it aids in faster processing compared to SVO sentence structure like in English?
So faster processing, I don't know. There must be experimental research on that. I don't know. But just thinking about, how we process comprehension, process language, there is no necessary reason to say that some structure would be, different structure would be processed different. Length, of course, whether there is embedding, of course, but if it is just 3 item SVO or SOV, I'm not sure there would be any reason to believe that they would be processed. They would be processed differently, but they would still have the similar time frame. But anybody doing sentence comprehension task could answer that.
Okay. The next question is about, can we rather have comic strips which can actually cover all the aspects we want to look in connected speech as an experimental task? Would love your suggestions on this.
See, again, you can do anything you like, right? It depends on the question you are asking. Most of the literature has been on picture description. Comic strip also gives a bit more of continuity. For this type of narrative, important thing is to have continuity, like a storytelling aspect, because then you can have data for future to do more of narrative analysis from macro-linguistic structure. Whatever you do, whatever task you do, you have to ensure that it's clear to the patient, it is visible, the type of lexical items you are choosing, they should be appropriate. And again, it all boils down to what is your question and what is your what you're trying to elicit. But to answer simply, anything with few events is a good idea rather than just one static picture.
Okay. The next question is about, would you suggest the following similar trajectory in exploring the linguistic features of languages that have not been researched much more upon, such as like Multani, which is spoken in Indian languages, in India? Like whether the results of the study is going to be like similar if we do the same kind of studies in a kind of a dialectual variations, or the very less limited spoken languages.
So your question is, if it is an interesting question to ask in other languages, the answer is yes. You should go ahead in any language, but again, you should know what you're looking for. And especially if you're looking at the linguistics, you make sure you have somebody in your team who understands linguistics. Second is, if it is a dialect, you have, again, if you want to know dialect very specific differences, then you have to see what are the specific differences in the two dialects of that language, and then you can explore that. Okay.
Okay. Did you ever think of using a book or a stimuli that was more indigenous to India or Bengali, as opposed to the frog Vedar storybook?
So I did spend a lot. I did not come across a book which I was happy with. And secondly, more importantly, the frog story, it's quite, children, it has been used in the literature. So I know there is data, it can elicit important things. I really wanted to not have features of, say, area specific cultural events like Durga Puja or this. I didn't want it to have those type of things, because if somebody wants to take it forward in other languages, so I wanted to have those cultural, and it should be culturally appropriate, but not very culturally specific. So it does not become, a task for one type of populations.
Okay, ma'am. This is a question from Akshaya S, a PhD scholar. She has proposing to study acquired reading impairments in post-stroke aphasias, and she is intending to look into cross-linguistic variations in Kannada and English reading impairments in persons with aphasia, whereas Kannada is a syllabic language and English is phonemic based. So I'm curious whether I can compare these. Like when I compare these two languages, will it be the right way to correlate, or should we study separately each language?
Yeah, so your question is at reading level, right? So
Yes.
if it is, it again depends on what is your goal. If your goal is to identify cross-linguistic differences, and in reading literature in aphasia and English, you have clear markers like surface dyslexia, phonological dyslexia, deep dyslexia. So if your goal is to identify those type of disorders, then you have to have tasks which can capture those parameters, right? For example, in deep dyslexia, one of the things is imageability, right? Imageability, testing the imageability through writing, it doesn't matter whether it is whether it's Kannada or English, you can come up with word list as such. But it gets more complicated what you say about syllable versus phoneme, grapheme, right? Grapheme based. Prema ma'am has many word lists. One of my PhD student, Anusha, did something similar, and we really found it difficult to actually come up with comparable stimuli set in 2 languages. It was almost not possible. So what we did then is to profile the English language deficits, reading and writing deficits, using what we have from English, which is quite a bit. And then we used a subset of tasks which we could get from Indian languages. And then we tried to profile separately. Okay, so that's what we took forward, rather than just trying to compare exactly cross-linguistically. Yeah. So I have to in 10 minutes. Do you think we can wrap up, Sunil?
Yes, ma'am, surely. This is regarding the Multani language. So the dialect of Multani in India hasn't been researched upon, whereas the Pakistani dialect of Multani language still have some data. So would it help to go ahead with the same goals?
With what goals?
Like carrying out these kind of studies and to see whether the similar trajectory is going to be observed.
Yeah, I think it's your question, right? If you want to go ahead, you should go ahead. Like, these are experimental, empirical questions which needs to be sorted. And, it's not necessarily that you will find differences, or you will or will not find differences. That's fine. So I think it's always useful to explore if you have the opportunity in terms of experimental work to be carried out, because there is much need in the area.
Okay. Another question is about, do bilingual aphasics lose their linguistic features similarly in 2 languages, or one of the languages are going to remain dominant?
That's a good question. It will boil down to several bilingual variables. Their usage a lot is usage and acquisition, so, and also modality. So one of the clients, a person with aphasia, he was English dominant, and in his speech there were a lot of intrusion from in Bengali, there were a lot of intrusion from English. So the pre-morbid and post-morbid language usage will have a big impact on the bilinguals. But you guys have my email address, right? So can I put it in the chat box? Please do get in touch if you if we don't get chance to speak today.
Surely, ma'am. I think I have Dr. Gopi Krishnan has a question for you, ma'am.
Hello, Gopi.
Hi, Dr. Arpita. I was just listening to your talk. In fact, just enjoying it. Oh, sorry, my camera may be a little weak. It's a little dark. I like darkness, in fact. Anyways, one question I just posed in the chat box, okay?
Yeah,
so
tell me.
I'm a speaker, ask you all basically. So my question was that, let me read that out. has any client or his or her significant others asked for improved sentence structure following dementia or say aphasia? So that means basically, because I work in a tertiary care hospital, therefore I can understand the pressure. Obviously, I deal with the acute care patients over here. So even a single word which has a communicative sense is actually ultimate for the patient as well as more than the patient, the family members actually. So now I understand that we are speech language pathologists, we are actually an applied say professional discipline. We draw inputs from linguistic psychology and several other disciplines, and then we try to apply that. But what I am trying to impart to my junior friends is that, as a speech language pathologist, because it's actually a big difference, because working as an SLP with a client versus conducting some sort of research or maybe guiding some sort of a research is entirely different. So I would say that when I work with a client who is in an acute stage, maybe 70 to 80 years of age, and if he says one word, something like a cup of tea, or say uta, meenu, or something of that sort, that makes a big difference to the client as well as his family. But whereas when it comes to the research, especially from a linguistic background or maybe a cognitive background, we need to have all this kind of things. So my question was that, has any client or his or her significant others asked for an improved sentence structure following dementia or aphasia, any of this neurological damage?
So
because it's fine over here, especially in the setting that
So are you asking the question, because the mic I could not hear properly, is the question is, does any of the clients request for improving their language production? Is that the question?
Yeah, especially the syntactic aspects of the syntactic structure of the language.
Yeah. So so the answer is yes, they don't ask it as syntactic structure, but one of the key difficulties right now we face, what you are saying, I agree, in the aphasiology literature, and the literature is towards more making it more functional and all these things. And the pressure on clinicians, right? They don't have time to do various syntactic kind of things. But if you see the sentence production literature, and also if you speak with non-fluent aphasics, one of the goals, they often say they want to speak better. They want to produce, they will not say, I want to say passive sentences. They will not say that, of course. But there is a strong desire to be able to speak again. Now, again, it boils down to the availability of resources, skill set of the clinician. Everything is what type of therapy you want to do. And a lot of the sentence production or syntactic therapies have been shown to be useful. And, if you see Cynthia Thompson's work, they have also now digitized all those. I have not kept up with that. But all that outcome of sentence production therapy had come from initial work on improving sentence structures or things like that. So to answer your question, I doubt anybody will come and say, teach me passives, but they do express a desire to speak better verbally. And that has been, I think, lost in speech language therapy, because the focus has become so much on, group therapy, functional therapy, that, that individual desire to improve their speech has been lost. Yeah, but I do appreciate the pressure on clinicians. People don't have the time. Yeah, so I feel quite fortunate to be indulged to do this, actually.
Can I just add, can you hear me? Arpita, this is Anima here.
Hi, Anima. I saw you in the thing, and I wanted to say I used your tool in one of the independent living. I'll send you that paper. Thank you.
Thank you so much. Thank you. But what I wanted to add is just a quick, Sunil, if you can just give me 2 minutes. Can I just add?
Sure, ma'am.
Yeah, I'm just following up on what Gopi asked. Now, I have been fortunate enough to follow up patients for more than 10 years. at least 2-3 of my non-fluents, and the sentence structures have improved so much. You will not believe where we started and where we are now.
Yeah.
Because the complexity of the sentence structure has changed so much. And the second thing is, Arpita, you were talking about a patient with AD versus aphasia. Of course, I didn't do an in-depth linguistic comparison like what you did, but I simply followed them up. I followed up a PPA patient and one post-stroke, both were non-fluent. And we just followed them at 3, 6, and 1 year just to see how they were doing on the WAB. So at the end of that study, when we compared both, it was interesting to see what were the subtests that were holding on the WAB and what were the subtests that, the patient degenerated at the end of a year in the PPA. And in the reverse, we studied the aphasic also, and we could see this pattern of recovery. So it was interesting to see comprehension was the last to go and comprehension was the first to improve in the aphasic, whereas in the PPA that was one finding. And similarly, like you said, when you specifically look like reading and between languages, we did study the bilingual Malayalam English patients, and of course we see certain patterns, or there are some differences and there are no differences in some of the tests. But like you said, it's only when we look for these things we will see them. And of course, it has to be systematic, and your research question has to be, what you actually want to study. So thank you for this very interesting talk, Arpita.
Thank you.
Thank you, ma'am. Ma'am, it is time now. So to wind up, I request Sonal Chitnis to propose the vote of thanks. Sonal?
It has been very clinically engaging, enlightening talk, ma'am. I think a lot of grammatical aspects which we actually could look, which when we carry out the connected speech discourse analysis in the patients, when we see be it aphasia, degenerative or vascular. So it has been a very nice lecture, and I'm sure all the audience have been really happy to learn so much from your great lecture. So I thank you for the great lecture, and from the ISHA clinical aphasiology, ISHA, I feel that we should have more and more lectures from and collaborative work from you, so that Indian aphasiologists, clinical researchers would get to learn. Gopi sir, please go ahead. Yes.
Because as Madam Karanth said in the beginning, I think now we shall be looking forward to more of a collaborative, especially when Dr. Arpita is interested in the language and she's basically an Indian. Obviously, I think the attendees of this program can definitely approach her, and I'm there, Dr. Arpita.
So thank you all for really listening. You still have queries after 1.5 hours talking to this, but I feel very encouraged. And some of the observations you mentioned from clinic, and also what Anamma said, the trajectory of decline and recovery is fascinating across different disorders. So yes, let's keep in touch. I have given my email ID, so please feel free to get in touch. And it's always nice to come back, and I hope when the pandemic is over, we can meet in person, not just in digitally, So thank you for your attention. Yeah.
Thank you so much, ma'am. I also thank Dr. Karanth, ma'am. She is our inspiring icon in aphasiology, and she's been always very supportive to all of us. So thank you so much, ma'am, for being with us. I thank Shivshankar sir, Anama ma'am, Dr. Rita Mathur, and all the audience. I thank our moderator, our EC, SIG Aphasiology, Dr. Sunil, and yes, Dr. Gopi Krishnan. Thank you so much all.
Thank you so much, Sunil.
Thank you and bye.
Thank you, ma'am. Bye.
Thank you. Thank you.
Bye.
Thank you, madam. Madam, thank you very much. Sorry, I couldn't speak to you earlier. Madam Karanth.
Thanks, Gopi. We will keep in touch. Yeah.
Yeah, sure.
All of us.
Thank you, ma'am.
Thank you.
Thank you,
and-
Ananda.
Shivshankar sir, good night.
Good night, sir. Bye.
No, we didn't hear Shivshankar sir. It's now off. but you can
I
get
think,
maybe for 5 minutes.
I think sir has left, sir.
Oh, okay, fine. Then leave. Yeah. Okay, good.
Bye,
Thank you, sir.
Gopi. Good
Thank you.
night. Bye,
Yeah,
Sunil.
yeah.
Bye, Sonal. Bye.
Thank you, ma'am.
Bye,
Thank you.
ma'am.
Bye, ma'am.
Thank you so much. Thank
It's
you all.